So we're spending about $2.5 trillion a year, 17% of the gross domestic product, on a system that produces population health statistics not much better than Cuba's. So if we want to solve the crisis before the cost simply overwhelms us, we've got to find a way to explain the discrepancy between this huge investment in medical care and these marginal returns in terms of health. There are three major reasons involved. First of all, our financing system, the financing component of the system, creates huge barriers to access for millions and millions of people, forcing them to delay needed care and often seeking care late through the emergency room when they're very, very sick. And the reason is that the financing component of the U.S. healthcare system was never built around a broad commitment to access. It evolved around something called categorical eligibility. Now, what does that mean? It means that in order to get publicly subsidized medical care in the United States, as opposed to publicly subsidized primary and secondary education or public safety services, you have to fit into a category. And those categories were created through a number of unrelated acts of the United States Congress, most of them in the last century. The first was the Tax Reform Act of 1954, which granted preferential tax treatment to employer-sponsored health insurance coverage. That was the point at which Congress said to employers, you can deduct from your taxable income the cost of your contribution to your employees' health care. And that's also not counted as taxable income for employees. So it's a publicly subsidized tax benefit for people who have workplace-based coverage. And that costs probably $250 billion a year now. Big subsidy. The next two acts, completely unrelated to the first, were the passage of Medicare and Medicaid in the mid-1960s. Now, those three components form the basic financing and eligibility structure for the U.S. healthcare system even today. And it consists of a public side and a private side. On the public side, you have Medicare and Medicaid, and then the state health insurance program for kids was added in the 1990s, and now the new federal bill, all on the public side. And on the private side, you have employment-based health insurance coverage. Now, in between the public and private arms of the system is a coverage gap. And that's where the 50 million people are who don't have any health insurance coverage. That gap exists because we organized our eligibility system around categories, not around a broad commitment to access. And if you think about it, the people in that coverage gap are people who don't fit into a category. They're not 65, so they're not eligible for the Medicare program. They don't meet the categorical or eligibility requirements for the Medicaid program or the S-CHIP program. They don't work for someone who offers workplace-based coverage, but they can't afford a policy in the private individual market. Now, that gap exists because the United States stands alone among industrialized nations in failing to explicitly answer the most fundamental question in the healthcare debate. And here's the question. In the United States, at the end of the day, who has the responsibility to pay for the healthcare needs of the growing portion of our population that can't afford to pay for it themselves? And because we never answered that question as a matter of explicit policy, by default we allow the economic market to answer the question for us. But economic markets are designed to make a profit, not to foster social responsibility. So it shouldn't come as a great surprise that nobody goes out and competes for people who won't pay them, right? So in our market-oriented terminology today, doctors and hospitals view people who can pay as market share at the end of the day. And people who can't pay are viewed as liabilities, and we've developed a variety of ways to avoid seeing them, the most insidious of which is called cost shifting. So when the people in this coverage gap get sick enough, or when they can't find a primary care provider in the community, they go to the emergency room, where federal laws, like EMTALA and others, require that they be seen and treated, and those uncompensated costs are simply shifted back onto the public and private payers through incremental increases in premiums or in bills. Now, those two public payers simply shift the cost back onto individual. Cost shifting is not the same as cost management or cost control. So states do it by simply changing the income eligibility requirements to reduce the number of people covered by the Medicaid program, essentially redefining the poor for accounting purposes. Yesterday you were poor, you're eligible for Medicaid. Today we've just changed the rules, you're no longer poor. You get to go into the coverage gap, and we've balanced our state budget. The private sector does essentially the same thing. Well, the public sector also cuts provider reimbursement rates, which at some point results in people not going out and competing for Medicaid patients and closing their practices to them. So both of those things have the effect of squeezing more people into the coverage gap. Employers do essentially the same thing. Either they increase co-payments and deductibles that shift out-of-pocket expense to individuals who at some point are no longer able to purchase coverage, or they drop coverage altogether. And it's important to note that private sector health insurance coverage is eroding at over 5% a year because of the cost. So both of those actions drive more people back into the coverage gap. They go back to the emergency room, and the cycle repeats itself. I suggest that this system makes absolutely no sense. It makes no sense from the terms of a business model or social policy, and certainly not a system that's trying to improve the health of the population. Now, there are people who say we can't afford universal coverage. I believe we can't afford not to have universal coverage, because actually we do have a policy of universal coverage in the United States. It's called the emergency room. So under the current system, we don't pay pennies to manage someone's blood pressure in the community, but we pay hundreds of thousands of dollars to take care of their stroke in the hospital after they get sick. It's a policy that says we won't ensure that all of our women have adequate prenatal care, but we're happy to pay the cost of resuscitating a 500-gram infant in the neonatal intensive care unit, and then shifting those incredible costs back to the shrinking employer community that's still willing to purchase them. This doesn't make any sense. And so the most fundamental step we have to take in the financing side of the system is to explicitly answer this question: who has the responsibility to pay for the health care needs of those who can't afford to do it themselves? This essentially was what the federal government was debating over the last year, and it sparked an ideologic debate, not about whether or not all Americans should have access to health insurance coverage. Everybody agreed on that. But the question was how to achieve that goal, and the debate was pitted people who felt that the larger role should be played by the private commercial insurance industry against people who believed that a larger role should be played by the government. And the bill that finally passed was a compromise of those. It relies on private commercial insurance, and it increases and expands public programs and public subsidies to make care more affordable. So while this bill will go a long way towards narrowing the coverage gap, it also increases the reliance on public dollars to make health care more affordable, and it does almost nothing to reduce the dramatic rate of medical cost inflation, which at the end of the day is going to bring the system down. Now, the second reason, so the first reason that we have this discrepancy between expenditures and health is this access question, which we're beginning to address as a nation, although not in a very elegant fashion if you had to watch the debate. The second reason, and this is by far a larger reason, is the fact that our system is designed to provide acute care rather than focus on prevention and wellness and the appropriate management of chronic conditions. The fact is that today, probably 80%, probably more than 80% of the cost in the system comes from treating people with one or more chronic illnesses like diabetes or coronary artery disease or congestive heart failure or asthma, etc. Furthermore, the way these expenditures are distributed around the population is very uneven. 1% of the population accounts for 35% of the healthcare spending in any given year. 10% of the population accounts for 70% of the healthcare spending. Now that brings to mind the bank robber of the 20th century, Willie Sutton, who, if you recall, was asked why he robbed banks and infamously replied, because that's where the money is. So if you want to solve this problem, it might behoove us to try to identify that 10% of the population that's driving 70% of the medical costs. Now, we know a lot about chronic illness. First of all, we know that most chronic illnesses can be prevented through lifestyle and behavioral choices. Diet, for example, contributes 90% to the development of type 2 diabetes. 80% lifestyle choices contribute 80% to the development of cardiovascular disease. We also know that once you get a chronic illness, they are gradually progressive, but we know how to intervene to slow that progression and to avoid the acute medical complications that end people up in an acute care hospital. But doing so requires a certain type of delivery model, okay? First of all, it requires that the individual is taken care of by a coordinated team of providers, where doctors work with doctors, primary care doctors work with specialists, and they all work with nurses and physical therapists and dietitians, and with the family and with the patient. Sharing of information, seamless handoffs, part of a common care plan. Secondly, it requires that we recognize that the patient with the chronic illness and their family is the most important caregiver in managing chronic disease. You can come and see me for your congestive heart failure. I can give you a little something to keep you from retaining fluid, but whether you take that medication or not, whether you change your lifestyle and take care of yourself at home is not a medical issue, but it has a huge impact on the ability of that person to manage chronic illness.